I'd like to start this case by stating that we corrected the severe compression fracture and kyphotic deformity of this patient with a minimal invasive direct thoracic interbody fusion. As you see, when patient is laying down, the kyphosis is about 40 degree that we are able to correct to 31, 32 degree, but when patient stands up before the surgery, that kyphotic deformity becomes about 50 degree. After the surgery, that stays 31 degree. So we have corrected significantly the kyphotic deformity with a surgery that is practically performed minimal invasive with keyhole incisions. In this surgery, as you see, patient underwent placement of cages in the thoracic spine. Patient has fallen, has no neurological deficit, conservative therapy has failed, and this patient is elderly, 75 years old, and has significant comorbidity and not a good candidate for thoracotomy, corpectomy, and practically open old-fashioned surgery would be very dangerous and have high morbidity mortality for this patient. So we decided to do this surgery with minimal invasive surgery by going with a small incision in the intercostal region to the disc base. Now this patient obviously has been conservatively managed before, and here we decide to perform the surgery in a minimal invasive fashion for this surgery. We start this surgery with two C-arm. We identify the anatomy, and we, in the AP and lateral view, we identify the fractured bone. And as you see, there's a wedge fracture here, where you see we are adjusting it for proper view of the discs below and above. First, the disc below. A K-wire goes in after we identify the levels. Then we receive some bone marrow that we mix with our biologic for later reuse. Then a neuromonitoring probe goes in, it enters, and we center it on the disc. We're stimulating at this point. Then we enter the disc with a small K-wire. We see the wedge that is broken bone. Once we enter the disc, a dilator goes in, and over the dilator, we put a tube that is 10 millimeter outside, 8 millimeter inside, and then a series of tools are used practically to remove broken pieces and create a fusion mass for later. So you see a drill, and then we use some discectomy tools, pack the place with tricalcium phosphate combined with bone marrow, and put the first cage in. Now we readjust our C-arms to get a better view of the level above the broken bone. Even though the bone is broken, there is still a little bit of a bone left, and we are going to put two cages. The two cages act like expandable cage and reduce the kyphosis as you saw before. Here in the meanwhile, we are putting few more K-wires and get more bone marrow for later use. Here you see that the second cage is going in. After we put a dilator in, put a tube in, do the discectomy, put some biologic in the place, and then you saw some fanning curette that just opened up the space. Biologic is going in and the cage is going in. So you'll be surprised that you still see some good amount of bone between. So the combination of remaining bone and two cages, it actually reduce the kyphosis and create a fusion mass in this location. This is obviously not as good as a expandable cage, but morbidity is much less in this surgery. So then we put the K-wires for 2 levels above and 2 levels below. Usually for open surgery I used to use 3 levels above, 3 levels below instrumentation, but now because I'm not disrupting the surrounding tissue, 2 levels above, 2 levels below is very acceptable. Here you see that we put the K-wires and or the Jamshidis, and then here you see that this device is called decorticator, where we go over the K-wire, center on the facet, grind the surface of the facet, and put some biologic in, and that helps us to achieve posterolateral fusion additionally to interbody fusion. So this is not posterolateral instrumentation alone, it's posterolateral fusion. The cages are going in. You see the rod passing in with the curvature of the spine. I first put the rod backward or upside down, and then once I pass the top of the spine, and then I turn it around and pass it through the screws, and then as you see, the first rod is being put and locked, and the second rod the same way. And now here is the final view of the spine. Now, toward the end of the surgery, we noticed that the O2 ZAT going mildly down. It was in high 90s and now it's in low 90s. As well, as you see, our approach is from the left, but anesthesiologist is telling me on the right side the breath sound was reduced. So obviously that is reason enough for us to get a chest X-ray. Now, having 1 in 4 or 1 in 5 mild pneumothorax is not unusual in this kind of approach. But here I think it's important to know that the pneumothorax, as you see here, is on the right side, not where our approach is. You see the vascular sign on the left side going all the way to the chest wall, but on the right side, as you see here, the contour of the lung and the no vascular sign. So when you see it in the chest X-ray, it's a quite big pneumothorax. Again, this is most likely related to age of the patient, inherited lung disease, and positive air pressure intubation and respiration during the surgery. That probably one of those blebs, as we call them, ruptured and caused pneumothorax, because we never traverse that side of the lung at all, and two lung sides are generally not connected, and lack of the pneumothorax on the site indicate that we have air leaks. I put a pigtail chest tube. You see the lung expands right away, and saturation numbers are improving. Here the CT right after the surgery, as you see, I'm going to put the axial and sagittal views. And let me first show the bone window. I want to see if any of my instrument could have violated the right lung. So we are going back and forth here. First, let's go in the axial, and as well here you see that the screws are perfectly positioned and no problem with the position of the screws, perfectly in place. So none of them is traversing any area that could have caused the right-sided pneumothorax. As well, you see the cage, the path of the cage, and the bottom screws in the T11 and 10. And here you see in the lateral or sagittal view again that screws are well positioned, no trouble with this screw placement. And the long window, and next I'm going to show you the long window. Which shows the lung is expanded in every area. There are some dependable positionally related small pneumothorax because air couldn't get to the chest tube. And here you see the long window, well expanded. And here you see that on the apical side there is a bleb. This is what the bleb look like in the MCT, and that is probably what ruptured and caused the pneumothorax. That sometimes you can have spontaneous pneumothorax with positive pressure ventilation. Now here we are coming toward the end. After we put the pigtail and patient is doing really well, I clamped the chest tube, and we got every 6 hours at X-ray, and here you see that there's the air leak. There's some pneumothorax again there. Not as bad as the first time, but in the apical area you don't see vascular sign. That's a hallmark of pneumothorax. And you see the border of the lung. Patient's still doing well. Obviously we put the chest tube back on suction and get more X-rays, and adequate follow-up X-rays show again that the lung is expanding. That is what we do. We cycle it. We put it on the suction, get the air out, and since the amount of the air is very minimal, after few hours, actually over the night. I put it on suction, then opened it up. Opened it up, and then in the morning I clamped it, and again every 6 hours. So this is the second day. There's still a very, very minimal pneumothorax. Patient's still doing great. So we are going to do again, suck the air out and cycle this. This is the last X-ray in the second day that shows that pneumothorax is very, very minimal now, and patient still doing clinically great. You see vascular sign all the way to the second rib, so meaning that the air leak is slowly closing itself. And at this point, practically we are going to just cycle it, and hopefully in a day or two we are taking it out. Now this is the incision look like in a similar case. Alternative to this is the open old-fashioned surgery with removing 1 or 2 ribs actually, and collapsing along, put the patient in the ICU for a week and so on. Very, very massive surgery. In our surgery, we entered the rib cage actually with a very small incision, less than a centimeter, and run the rib, put our probe on the top of the disc and enter the disc with double C-arm, and as you see, the incision at the end of they are very small, much less morbidity with this procedure. Here you see post-operative CAT, an X-ray of another patient, and this is actually a patient. You see the 4 incision for the screws and 1 incision. Actually, this is 6 incision for the screws, 2 incision for the cages. This patient do very well. Most of them go home next day. If you Google Abbasi, ABBASI, MIS DTIF for direct thoracic interbody fusion, and NIH, you see our first paper that was published 6 years ago, as well as our next paper is being submitted as we speak. Well, thank you so much, and you can contact me if you want to learn this procedure or you have question.